students, this is your Dr. Prats and welcome to my masterclass. So from the last week we are talking about odontogenic cysts. These are the cysts which arise from odontogenic epithelium. Today we are going to discuss about three important cysts: Dentigerous cyst, Eruption cyst and calcifying epithelial odontogenic cyst, or shortly called as CEOC. Let's roll. As usual, we'll follow the same format. What is the pathology? Why do we need to understand it as a dentist? The three hows, that is, how did it occur? Nothing but etio-pathology. How to diagnose using various investigations, that is your X-ray and histopathology or any other method. And finally, of course, the most important, how to treat it. The entire lecture will be followed by a brief summary and a few MCQs to let you understand the tips and tricks behind answering it. Every lesson has to have an objective. So when it comes to pathology, it is very important to correlate your clinical feature with the radiography and histopathology to arrive at a diagnosis, and that follows the treatment. So for each pathology, the learning objective is pretty much similar. You need to understand the etio-pathogenesis, followed by all features individually, and learn how to correlate it to arrive at a diagnosis. So the three cysts, like I said, we are going to study today is Dentigerous cyst, Eruption cyst, and calcifying epithelial odontogenic cyst. So Dentigerous cyst is one of the most common cysts which is associated with the impacted tooth. As you can see here, this is a tooth which is impacted. How you can differentiate it from the erupted tooth? Erupted tooth is above the level of the bone, whereas impacted tooth is within the bone, right? And this will be something which you can appreciate in a radiography. Clinically, of course, you cannot see it. So dentigerous cyst attaches to the neck of the tooth and surrounds the crown like that. Okay, so this is a gross specimen of the same cyst, dentigerous cyst. So you can see that the cyst is attached to the neck of the tooth or the cemento-enamel junction, and it surrounds the crown in this manner, and hence it is called as pericoronal cyst. It is also called as follicular cyst. Why? Because the fluid accumulation is within the dental follicle. It is normally seen in the first 2 decades of life, that is in younger people, and both the genders are equally affected. Because I said in the beginning, the cyst is associated with the impacted tooth. So it is logic that the most common site would be the most commonly impacted teeth, that is your mandibular molars and maxillary canines. Okay. Clinically, you can see that here the dentigerous cyst is associated with an impacted canine. Okay, it is very slow growing and it is usually asymptomatic. And normally when you're taking a radiograph for some other lesion is when you will discover that there is a cyst associated with the impacted tooth. Or maybe the patient will come and tell you that there is a tooth which is not erupted. Can you check what's wrong with me? And that's when you realize that there is an impaction of the tooth followed by cyst associated with it. I told you that they're usually asymptomatic, but it might not be the case every single time. When they're very large, there could be swelling of the jaws, meaning the patient might not complain of any pain or any other symptom, but you can observe that there is painless swelling of the jaws and even patient might be noticing it. This could also cause displacement of the adjacent teeth, because whenever a cyst grows larger in size, it's going to apply pressure on the adjacent teeth and that will result in dislodgement or displacement. And if it's really, really big, then it can cause facial asymmetry. So, facial symmetry is the face is symmetrical on both sides of the midline. And when there is an asymmetry, that means that on one side there is a swelling or some sort of distortion. There can be pain associated in some instances, and that indicates that the lesion is secondarily infected. There might be some kind of bacterial invasion, and that might have resulted in an infection followed by pain. Sometimes adjacent teeth can fail to erupt or they can become tilted. Like I said, it gets displaced. So, clinically, when you're looking in the oral cavity, it looks as though it is suddenly tilted at an angle. Excessive enlargement can cause thinning of the cortical plate. And this on palpation can sound like an eggshell crackling. Radiographically, it is quite obvious that it is associated with an impacted canine. Okay, it's the same clinical picture which I showed you. And the small asymptomatic lesions are usually unilocular. What is the meaning of unilocular? This radiolucency which you are seeing appears as a single locule. Multilocular means there will be kind of septae in between or differentiating the locules in between, which gives it a multilocular appearance. I'll show it to you in the coming slides. Here in this case, because it is still small, you can see that it is associated with an impacted tooth and that it is unilocular. It's a well-defined radiolucency. What is the meaning of well-defined? Well-defined means that the surrounding or the periphery of the radiolucency shows some kind of sclerotic activity. Hence, the border between the abnormal and the normal is very clear. Okay, so this is a defense mechanism of the body. Whenever there is kind of a resorption or some kind of pressure applied by the lesion, the body tries to defend itself, that is the bone in this case, by forming sclerotic bone to protect itself. Okay, so this is also an indication that the lesion is slow growing. If the lesion is very fast growing and if it is aggressive, then there will not be a clear border between the lesion and the surrounding bone. Okay. I told you that the lesion is unilocular in this case because it is still small. They can also be multilocular when the lesions are pretty big in size, like here. So this is the impacted tooth, and the Dentigerous cyst, as you can see, is quite big, okay? And it is involving almost the entire angle as well as the body of the mandible, as you can see, and there are multiple locules, okay? So this is a multilocular appearance. So for a lesion to be diagnosed as a dentigerous cyst, there is certain criteria. This you will also come to discuss later when we are talking about the differential diagnosis. Because one of the most important differential diagnosis for a dentigerous cyst is a normal dental follicle, which might be just enlarged. So for that reason, the criteria for diagnosis radiographically is that the cyst should be at least 3 to 4 millimeter in diameter. That rules out the possibility of a normal dental follicle and leans more towards the diagnosis of a dentigerous cyst, which of course has to be followed by histopathological diagnosis. So in the previous picture, you saw how there was a very big lesion involving almost like half of the body of the mandible and the angle of the mandible, right? So expansion happens to be a very, very important feature associated with the Dentigerous cyst. So, like in the image, also you saw that body was involved and the angle of the mandible, but it can even go up to entire ramus and to your processes, that is your coronoid process and the condylar processes. And it could even cause the expansion of cortical plates, which can be appreciated better on a MRI or a CT scan. You can see that it has caused the expansion of the cortical plate. This is the dentigerous cyst associated, and this is the expansion of the buccal cortical plate, as you can see here. And this is a lesion of a 24-year-old man associated with the dentigerous cyst. You can see that body, angle, ramus, and it has gone up to the condyle and coronoid process. Yeah, you can appreciate it very, very clearly. So expansion is very important feature with dentigerous cysts, which are bigger in size, not with the unilocular and the small asymptomatic lesion, but the ones which grow very, very big. So whenever there is a cyst, I told you it puts some amount of pressure on the adjacent teeth, and that could cause either displacement of teeth into lower border of mandible, ascending ramus, that is in case of lower teeth. And when it is associated with the upper teeth, it could go to floor of the nose and maxillary sinus and even up till the floor of the orbit. The pressure is pushing it basically. Okay. Sometimes the dentigerous cyst is not just associated with one impacted tooth on one side, it can be bilateral. Okay. And whenever you see a bilateral dentigerous cyst, you must doubt an association with basal cell nevus syndrome, cleidocranial dysplasia, and a rare form of amelogenesis imperfecta. It could also occur in multiple sites. So in such cases, again, you have to see any other association of diseases. Let's go to radiographic types, which are described according to Thoma. The first and foremost type here is central. As you can see, this is the crown. It is projecting into the cystic cavity, and the cyst itself surrounds at the neck of the tooth or at the cemento-enamel junction. Okay, that's central. The next type described is lateral, where you can see that the cyst is hanging on the sides of the tooth or the lateral surface of the tooth, both in association with the crown and the root. And there is another type called as circumferential, where you see that the cyst is surrounding entire crown and the root, kind of extending along the lateral surface of the root, as you can see here. So it looks like it is surrounding the tooth itself. So it is called as circumferential type. Let's talk about histopathology as a form of investigation in case of dentigerous cyst. So in histopathology, you have to correlate it with the etiology. There is fluid accumulation between the crown and the dental follicle. Follicle is nothing but reduced enamel epithelium, which is around 2 to 4 layers of cuboidal cells. Okay, so that is your epithelial lining. And it is non-keratinized. As you can see, there is no keratin on top of the epithelium. The connective tissue is formed of loose connective tissue. It's not very dense and composed of young fibroblasts. So basically it indicates that the fibroblasts are active. Sometimes it need not show the typical picture of 2 to 4 cell layer primitive epithelium. It can show varied thickness, as you can see here. Yeah. Another important feature associated with dentigerous cyst is absence of rete-ridges. So whenever there is a confusion like varied thickness and when it is not showing a typical epithelial lining, a diagnostic feature could be that it is showing an absence of rete-ridges. Okay. And why there is a change in the varied thickness? The reason could be the presence of inflammatory cells, which has changed the behavior of the epithelium. But when you correlate all of them, that is your etiology, the clinical picture, the radiography, and histopathology, then you can confirm the diagnosis of Dentigerous cyst. Another diagnostic method which could confirm the diagnosis of Dentigerous cyst is FNAC, or fine needle aspiration cytology. So when you aspirate the content of the cyst, it usually is thin, watery in consistency, and the color of the fluid is yellow. Sometimes it can show presence of some RBCs, but normally it is thin, watery, and yellow in color. So that could be diagnostic even before you do the surgery itself. So differential diagnosis, I told you when I was discussing the radiographical features that one of the most important differential diagnosis is a normal dental follicle, and I've also told you the criteria that the radiolucency should be at least 3 to 4 millimeter in diameter for it to be diagnosed as a dentigerous cyst and not a dental follicle which is just enlarged. The second differential diagnosis is adenomatoid odontogenic tumor. You will be learning about it in the other series, which comes under odontogenic tumor. Why it is a differential diagnosis is because of the site. They occur commonly in relation to the maxillary canine and are associated with young girls and appear similar in a radiography, and that is why it is a differential diagnosis. How will you differentiate it from the dentigerous cyst? After the histopathology, the diagnosis will be very, very clear because both of them have varied histopathological picture. The second is calcifying odontogenic cyst, because even this can occur as pericoronal radiolucency, but it will contain evidences of calcification. You will see the radiographic picture of this particular cyst at the end of the lecture, so watch out. So that will be a differential diagnosis radiographically, and again, histopathology is the gold standard of the diagnosis, guys. Always remember, histopathology is the gold standard. So no matter what confusions you have during the clinical scenario or later when you take a radiograph, your confusions will vanish and the diagnosis will be confirmed after histopathology. And if there is a confusion in histopathology itself, there are other histotechniques by which you can confirm the diagnosis. How will you manage dentigerous cyst? Because that's the most important aspect, isn't it? The patient is coming to you for a particular reason. Whenever the lesion is very small, enucleation is sufficient and there will not be any recurrence. Dentigerous cyst is not a cyst which poses a problem like recurrence. Once you treat the lesion, that's it, the patient is good. When the lesion is larger, then you might have to do drainage and marsupialization. Marsupialization is nothing but when the lesion is very huge, the dentist creates a kind of a small window. Let me just draw it and show you. So suppose the lesion, this is the mandible. Okay, and the lesion is very big like this. So when you remove the entire lesion like this, it leaves behind a huge cavity for the patient to heal or the body to heal. So sometimes what the surgeon does is he creates a small window like this. Okay, he he cuts open a small window so that the pressure is released. There is a drainage of the cystic fluid and the cavity is filled with the granulation tissue. It shrinks in size later on and will be later removed by enucleation or in toto removal. Like I said, recurrence is uncommon in case of dentigerous cyst. But there are some potential complications which we must be aware of. One such complication is development of ameloblastoma from the lining of dentigerous cyst and the development of mucoepidermoid carcinoma. So both these are very aggressive tumors. So ameloblastoma you will be studying again in the other series of odontogenic tumors. It is considered as one of the most aggressive odontogenic tumors and also a common one. Mucoepidermoid carcinoma is a salivary gland tumor and it is a carcinoma, it is a malignant tumor. So these two are the potential complications of dentigerous cyst, and that is why it is very important to treat the lesion as early as possible. The next cyst we are going to discuss today is eruption cyst. Eruption cyst is nothing but a type of dentigerous cyst, guys, okay? So it is associated with an erupting tooth, and that is why it is called as eruption cyst. And it is seen within the soft tissue which is overlying the bone. It is not really seen inside the bone. It is seen in the soft tissue which is associated with an erupting tooth. And again associated with canines and molars, and apart from that, incisors are the most commonly affected teeth. The cause for this is unknown. So in this case, I cannot really tell you the etio-pathogenesis of the lesion. Clinically, normally it is associated with an erupting tooth, and that is why the name eruption cyst, right? Sometimes it appears bluish or reddish like this. This is because, especially when it is associated with anterior teeth, or where there could be some amount of trauma and internal hemorrhage, that results in appearance of a hematoma. So the other name for eruption cyst is eruption hematoma. Okay, so it can appear as circumscribed, fluctuant, and translucent swelling normally, but whenever there is internal hemorrhage, it appears as bluish or purple in color. Radiographically, there will be an expansion of the normal follicular space of erupting crown, as you can see here. Okay, so this is your deciduous tooth, and this is the erupting permanent tooth. In this case, it's an incisor. You can see that there is a slight expansion of the dental follicle surrounding the erupting tooth. The treatment is not required. You can just wait over and the tooth erupts on its own through the cystic cavity, and that's it. You don't have to do anything. But if in case it fails to do so, then a simple incision on top of the cyst will suffice as a treatment. The last cyst we are going to discuss today is calcifying epithelial odontogenic cyst. Yay! So, the name itself says that it is an epithelial origin, it is an odontogenic cyst, and shows calcifications. This was described by Gorlin and his associates, and that's why it is also called as Gorlin cyst. It is very common in children and young adults. Let's talk about the pathogenesis as to what results in this epithelial cyst. So the pathogenesis behind this are quite a few. First is the remnants of dental lamina. If you remember from oral histology, once the hard tissue formation begins, the dental lamina starts to deteriorate or disintegrate to form some kind of clumps of epithelial cells, which are called as epithelial cell rests of Serre. So these cell rests actually are the reason behind a lot of odontogenic cysts and tumors, because these have the capacity to multiply and to induce a pathology whenever there is a trigger. Stellate reticulum, which was the star-shaped network of cells which we see in enamel organ during the tooth development. Reduced enamel epithelium. So once the tooth formation is complete, the swelling can be associated with pain, and it is usually central or peripheral. Central meaning it is present within the bone, and peripheral means it arises from the soft tissue. Okay, that's the difference between central and peripheral. The peripheral cyst can cause saucer-shaped depressions on the surface of the bone. 65% of them occur in either incisor area or the canine area, that is your anterior teeth. And radiographically, you can see that there is presence of calcifications. Can you see here? So this is a calcification here. And here are a few calcifications which you can clearly notice. So these are radio-opaque structures, that is the calcifications, and they can be either irregular in shape, as you can see in both these x-rays. They're quite irregular in shape, but sometimes they can even appear like tooth-like structures or tooth-like densities. So the cyst itself is radiolucent, and it is associated with an unerupted tooth, and most often canine is the commonly affected. And the size can go up to 2 to 4 centimeter in its greatest diameter. Root resorption, or the divergence of adjacent teeth, is seen with some frequency, as is the case with some other cysts which can grow slightly bigger in size. And when it applies pressure on the adjacent teeth, you can see some amount of resorption as well, apart from tilting or the divergence. Histopathologically, it has very unique features which is called as ghost cells. So what are these ghost cells? You can see here, these are the ghost cells. Okay, so this is the epithelial lining, and this is the connective tissue wall, and you see these structures which are called as ghost cells. So this is a close-up of the ghost cells which are present in the epithelial lining. So this is another good image of ghost cells which you can see. And you will also see hematoxyphilic calcifications within the ghost cells as well. Okay. Dystrophic calcifications are what they're called as. So they are the altered epithelial cell which is characterized by loss of nuclei, although preserving the basic cell outline, as you can see here in this image. Okay. The nuclear remnants can be seen in this case, and sometimes even remnants of cytoplasmic organelles and numerous tonofilaments can also be seen. You must differentiate the ghost cells from normal keratotic squames. Because they're bigger in size, nuclear membrane in ghost cells are more prominent, and they lack intercellular bridges, which can be seen in association with keratotic squames. So that's how you differ the two. And the treatment normally for a calcifying epithelial odontogenic cyst is enucleation. Do not get overwhelmed, like I told you. Always correlate etio-pathology with the clinical picture, radiography, and histopathology. Arrive at your differential diagnosis and final diagnosis, and list out your treatment options. So we studied 3 cysts today: Dentigerous cyst, Eruption cyst, and calcifying epithelial odontogenic cyst, correct? So in a Dentigerous cyst, clinically associated with an impacted tooth and surrounding the crown of the tooth. Yes. And radiographically, you can see the same picture a unilocular radiolucency, sometimes a multilocular radiolucency, and the lesion has the capacity to expand, so can involve the entire mandible. Histopathologically, you will see 2 to 3 layers of cuboidal epithelial lining and a very loose connective tissue underneath, mimicking a dental follicle basically. Treatment is enucleation in case of smaller lesions, and bigger lesions you'll have to do surgical drainage, marsupialization followed by enucleation. So that was dentigerous cyst. Eruption cyst is a type of dentigerous cyst, but it is not intrabony. It is present on the soft tissue on the surface of an erupting tooth. Radiographically, you will see a slight enlargement of the dental follicle. Histopathologically resembles a dentigerous cyst. Treatment is not required, but sometimes might require a simple incision. The third cyst was calcifying epithelial odontogenic cyst, also associated with an impacted tooth and is seen as a unilocular radiolucency. But you will see calcifications on radiographs, which can be irregular in appearance or could even appear as tooth-like densities. The histopathology shows presence of ghost cells, which are the most unique and characteristic feature of calcifying epithelial odontogenic cyst. Treatment is enucleation. This is an image which I'm going to put up at the end of every lecture of the cyst, just for you to remember what is what, where it is seen in a very quick look. Okay, so today we talked about eruption cyst. E is for eruption cyst. You can see it is associated with an impacted tooth and is present on the soft tissue. Okay, and the next cyst which we studied was the dentigerous cyst, associated with an impacted tooth and surrounding the crown of the tooth and is attached at the neck of the tooth. Characteristic of dentigerous cyst. CEOC is not shown here. Okay, so dentigerous cyst and eruption cyst for you to remember from this picture based on the topics discussed today. All right. So let's answer an MCQ. A patient who is 24 years old comes to you and he says that there is a swelling on the mandible. And when you examine, you see that there is a swelling and it is cystic in nature, meaning soft and fluctuant. And when you aspirate, you can see that it consists of thin watery yellow fluid and it has few RBCs present. So this could be a case of which cyst? Is it an eruption cyst? Is it a dentigerous cyst? Is it a CEOC or is it an eruption hematoma? Let's see how we can rule out the options. So eruption cyst and eruption hematoma are one and the same, isn't it? This is just another synonym based on its clinical appearance. So eruption hematoma, if at all we did an FNAC, would show a lot of blood cells because it's internal hemorrhage. So slightly blood tinged will not match it. So that means both the options will go, eruption hematoma and eruption cyst in that case. But suppose the eruption cyst was translucent, but still the site of eruption cyst is anterior teeth and it is a soft tissue swelling, whereas here we're describing swelling in relation to the ramus of the mandible. So this doesn't match, so both these options are gone. You're left with dentigerous cyst and calcifying epithelial odontogenic cyst. There is no mention of any calcifications in the description. So we can rule out the calcifying epithelial odontogenic cyst, whereas dentigerous cyst, the site matches because it is associated with the lower molars and is capable of expansion involving ramus of the mandible, the body, angle, and even up to condyle and coronoid process. And FNAC shows a thin watery yellow fluid in case of dentigerous cyst. So your answer should be dentigerous cyst. This is how you rule out a multiple choice question. You must not jump into your answer. You must not depend on your knowledge from the rote learning. Do not do that. Try to correlate everything, all your features, that is clinical, radiographic, histopathology, any other investigations like FNAC in this case, and then come to your answers. So this is very similar to how you come to your diagnosis even in a clinical scenario. So for more such questions, visit my website. The details will be given at the end of the presentation. And there are several such multiple choice questions for you to practice for your benefit. These are my references, students. I have referred to all standard textbooks of pathology and this particular textbook of Odontogenic Cyst itself by Mervyn Shear to give you all the data. And this is for an undergraduate level. It is sufficient for you to understand and to retain all the information. So, if you liked what you saw today, please subscribe to my channel and press the bell icon for notifications of such new presentations. Thank you and keep smiling.